Hello, my name is Anupam Basu from Cook County Health. I'm going to be presenting and discussing an interesting case of peritoneal mesothelioma. The case revolves around a 64-year-old male patient with past medical history of hypertension, no recent history of abdominal pain or melena. He denied fever, chills, or weight loss, pertinent past smoking history of 10-pack years, quit 30 years ago. He was referred for clinical follow-up following a CT of the abdomen and pelvis, which was performed after a motor vehicle accident. Select axial CT images with IV and oral contrast through the upper abdomen demonstrate peritoneal thickening and prominent omental caking within the anterior abdomen, as shown by the white arrows. FDG PET CT axial and coronal fused images demonstrate hypermetabolic omental caking with maximum standardized uptake value of 9.2, as depicted by the white arrows. Percutaneous CT-guided omental core biopsy was performed. Hematoxylin and eosin stained section at 40 and 200x magnification show nodular proliferation composed of monotonous cells with clear cytoplasm and no mitotic figures. A group of these cells are shown between the two black arrows. These cells stained with calretinin and WT1, which confirmed their mesothelial origin. CT is the first-line imaging modality for patients suspected of having peritoneal mesothelioma. CT imaging typically reveals peritoneal masses or omental caking, which may be associated with calcified pleural plaques, suggesting prior asbestos exposure. Prior asbestos exposure is less common in peritoneal mesothelioma than the pleural counterpart. FDG PET-CT is an important imaging modality which can assess peritoneal diseases, though there's considerable overlap between benign and malignant processes. A standardized uptake value greater than 5.1 has been shown to be helpful, though not completely reliable, in differentiating benign from malignant peritoneal disease. Cross-sectional imaging can also guide biopsy, which helped confirm in this case after other more common causes of peritoneal masses and omental caking had been excluded. Differential diagnosis includes peritoneal carcinomatosis, pseudomyxoma peritonei, tuberculous peritonitis, and serous papillary carcinoma of the peritoneum. Peritoneal carcinomatosis with omental caking is often seen in the setting of peritoneal spread of malignancy and can appear similar. This is often secondary to GI tract or gynecological malignancies, which were excluded in this patient based on imaging and clinical history. Pseudomyxoma peritonei features mucinous dissemination after rupture of mucin-producing tumors at other sites, also most often arising from the GI tract or ovaries. Tuberculous peritonitis can appear similar on CT and PET imaging. Peritoneal TB features include a wet, dry, mixed, or fibrotic CT appearance. TB peritonitis is more likely in patients with a history of prior pulmonary tuberculosis or immunocompromised patients. Serous papillary carcinoma of the peritoneum is a rare primary tumor of the peritoneum. Unlike malignant peritoneal mesothelioma, it is found predominantly in elderly women and postmenopausal women, also making it less likely in this clinical setting. Take-home messages from this case are as follows. Mesotheliomas are rare neoplasms which can arise from any serosal membrane. The majority of mesotheliomas arise within the chest. 20 to 30% of primary mesotheliomas arise within the peritoneum. Risk factors for primary peritoneal mesothelioma include asbestos exposure, chronic peritonitis, and prior abdominal radiation. In general, the prognosis for malignant peritoneal mesothelioma is poor, with mean survival of approximately 1 year. I hope you found this case useful and interesting, and thank you for listening.